My name is Rula Tamimi. I'm a cancer epidemiologist, and I'll be talking today about the epidemiology of breast cancer and COVID-19 and the impact on disparities. I have no financial or any other disclosures to make. So the question I have before we get started is, we know that racial disparities in breast cancer exist. So which of the following best describes the disparity as it relates to breast cancer? A, Black and Hispanic women are more likely to be diagnosed with breast cancer than white women. B, Black women are more likely to be diagnosed with breast cancer and to die of breast cancer than white women. C, although white women have the highest incidence rates of breast cancer, Black women have the highest mortality rates. Or D, Black and Hispanic women have higher breast cancer mortality rates than white women. So in terms of the format of my talk, I'm going to talk about four main things, and these are the main objectives. So I'll go over the descriptive epidemiology of breast cancer, really with the objective of everyone understanding the burden of breast cancer and how incidence and mortality rates vary by race and ethnicity. We'll take some time to go over the risk factors for breast cancer with the objective of understanding important risk factors for breast cancer and understanding which risk factors may be modifiable. And of those which might have the most impact in terms of breast cancer prevention. Then we'll talk about the descriptive epidemiology of COVID-19, really with the objective of understanding racial and ethnic differences along the continuum of COVID-19 disease. And then finally, we'll talk about the impact and implications of both of these for the future of breast cancer disparities. So as many of you know, breast cancer is the #1 cause of cancer among women in the United States. It's estimated that there are over 260,000 new invasive cases of breast cancer diagnosed every year. So this accounts for about 30% of all cancers that are diagnosed in women. In terms of cancer mortality, breast cancer is the #2 cause of cancer mortality among women. It's only second to lung cancer and accounts for 15% of cancer deaths in the United States. This graph shows the age incidence curve. So it shows us incidence rates across different age groups. And I think there's a number of different things that you might be able to notice. I think one is the shape of the curve. So one of the things that you see is that after the age of 30, incidence rates really take off, and there's a steep incline in terms of the incidence rates of breast cancer. And then it begins to plateau. Really, after the age of 50, we see the incidence, the rate of increase starts to plateau. And this is something that is common to hormone-related cancers, and we know that breast cancer is a hormone-related cancer. The other thing that I think you can see is that, that there are incidence rates that vary by race and ethnicity. So this blue line is for white women or European American women, and they have the highest rates, especially at these older ages. African American women are in this red line, and then we have Asian American and Hispanic women and American Indian women, these three lines that sort of travel together at much lower rates. I think the other thing that you can see is really, I think it's important to look at the age incidence curves. African American women have higher incidence rates at the younger ages, and then these curves really cross, and white women have higher incidence rates after the age of 50. So I think it's important to understand the incidence rates across the age spectrum, really, especially when we think about screening, when we start screening, and when we end breast cancer screening. This graph shows us the trends of breast cancer incidence over time. And this graph starts in the 1970s. And I would focus really, I think, on this bright pink line here, which shows us the incidence rates since 1975 in women over the age of 50, which is the majority of breast cancers do occur over the age of 50. And what we see is that there was a dramatic increase in the incidence rates of breast cancer in the 1980s. And this is largely attributable to widespread mammographic screening. With screening, there was more detection of cancers, and that results in this dramatic increase. We see a little bit of an increase over this next time period, and I think this is also attributable to changes in risk factors that we see as secular trends. So we do see Many risk factors are reproductive factors, so women delaying childbirth, women having fewer children, those are both risk factors for breast cancer. We know that over this time, there's also an obesity epidemic. Postmenopausal obesity is an increased risk factor for breast cancer. Hormone therapy, both exogenous hormones that can be through oral contraceptives or through menopausal hormone therapy, also increasing during this time, which are associated with increased risk of developing breast cancer. There is one blip here, one little decline that happened around 2000, and this is thought to be attributable to the publication of the Women's Health Initiative. This was a randomized control trial of hormone therapy, and the publication demonstrated that there was an increased risk of breast cancer for women taking estrogen plus progesterone hormone therapies, and a number of women discontinued use at that time, and that reflected in a measurable decline in breast cancer incidence rates. But since that time, incidence rates have really been pretty level, which tells us that prevention efforts are not really making meaningful impact in terms of reducing the incidence rates of breast cancer. So there's still a lot of work to be done in terms of identifying messages and identifying opportunities for prevention that results in declines in incidence rates for breast cancer. So in terms of established risk factors, there are a number of established risk factors, and I've color-coded these according to sort of modifiable versus non-modifiable risk factors. So we know that age, family history, having a prior benign breast disease or even a benign biopsy are risk factors for breast cancer. Reproductive factors, some of the ones that we talked about already, when you have your first child, if you have a first child, how many children you have, when your first menarche is, and when you go into menopause are all factors that are associated with breast cancer risk. Endogenous hormones, so we know that postmenopausal estrogen levels and androgen levels are associated with breast cancer. I would consider most of these factors non-modifiable. In terms of the yellow, I think people could argue that they are or they are not modifiable, but we know that breastfeeding is a protective factor for breast cancer, especially for triple-negative breast cancers. Radiation is a risk factor, a positive risk factor for breast cancer. Mammographic density is a strong risk factor for breast cancer. Increasing mammographic density is associated with increased risk of breast cancer. I think the green ones, I think people would more unanimously agree are more modifiable. Exogenous hormones, primarily menopausal hormone therapy, alcohol, certain diets can be preventive for breast cancer. Adiposity is a risk factor, especially for postmenopausal breast cancer, and physical inactivity are all established risk factors for breast cancer. I put together this chart because I think not all risk factors are identical. Some, even though they may be established and well-established risk factors, they're really associated with maybe a little bit of an excess risk, but there are other factors which are stronger. So this table is really meant to kind of expand a little bit more on what we just talked about and give a little bit more flavor in terms of what the magnitude of the associations are. So in terms of reproductive factors, this tells you about the direction of the risk factor, but also the magnitude. And so you can see having a first birth after the age of 35 is a much stronger risk factor, say, than age at first menstrual period. When we're talking about hormone therapy, there are different formulations of therapy and there are different durations, both of those which are associated with increased risk. And so really long-term use of E plus P types of hormone therapy are strong risk factors for breast cancer. In terms of modifiable factors, I would say the two here that have the strongest associations are really this long-term menopausal hormone therapy use, as well as weight gain post-menopausally. Some of these other risk factors, as you can see, alcohol is a positive risk factor, but in terms of its strength of magnitude is less than adult weight gain. And then there are some risk factors like breast density, which are very strong risk factors. Same with family history, I would consider a strong risk factor, but these, again, are not considered modifiable risk factors. Some of my research work has been done to try and estimate if we could eliminate these risk factors, or if we could get women to change from one risk category group to another risk category group, how much breast cancer would we prevent? So this was sort of a hypothetical exercise that we did, focusing on modifiable risk factors in primarily postmenopausal women. And so what this tells us, if we just look at weight change since age 18, we found that weight change since age 18 was the #1 modifiable factor. If we could sort of eliminate weight gain, we would prevent overall 19% of breast cancers from happening. Because this is primarily driven by excess adipose tissue, which is related to circulating estrogen levels, this would really be preventing almost 24% of estrogen receptor positive breast cancers. Sort of the next strongest risk factor would be menopausal hormone therapy. So we would interpret this as meaning if we could take people that are currently taking menopausal hormone therapy and sort of turn them into people who've never been on menopausal hormone therapy, we would prevent about 10% of breast cancers from occurring. And again, because it's largely through hormone-mediated pathways, it would have a stronger effect on the ER-positive breast cancers. And then you can see, again, you sort of mentioned that alcohol is a weaker risk factor. And so if we took all the drinkers and turned them into non-drinkers, we would be eliminating 6% of breast cancers. And it seems to be sort of more equivalent here across the ER positive and the ER negatives. So up until now, we've talked about incidence of breast cancer or the risk of getting breast cancer. But I think another way to also, and another important way to look at burden of breast cancer in our populations is also to look at mortality rates. And so what this graph does is it sort of shows us both the incidence rates for breast cancer by race and ethnicity, and also overlays in the brighter pink, hot pink, the mortality rates for breast cancer. And so you can see, again, this is similar to what we saw previously. White women have the highest incidence rates for breast cancer in the United States, followed by Black women, and American Indian, Hispanic, and Asian women have the lowest incidence rates, and it's relatively comparable across those three groups. In terms of mortality rates, though, you can see that non-Hispanic Black women have the highest mortality rates across all of the racial and ethnic groups. And what we've been talking about, breast cancer is sort of a single disease, but really breast cancer is a heterogeneous disease. There are many ways to describe that heterogeneity. I think one of the most common ways that we use to describe it, especially in the clinic, is by molecular subtypes, because that helps to determine treatments and prognosis for breast cancer. So we do see that there are differences in these molecular subtypes by race and ethnicity. And this bar graph here gives us a demonstration of what those frequencies are by race and ethnicity. So among all racial and ethnic groups, this hormone receptor positive, HER2 negative, or luminal A type breast cancer is the most common type of breast cancer. But I think one of the biggest differences that we see by race and ethnicity is that non-Hispanic Black women have the highest percentage of hormone receptor negative, HER2 negative, or triple negative breast cancer compared to white women and compared to other women of other racial and ethnic groups. And this is important because we see differences in terms of prognosis with triple negative breast cancer. So this graph here shows us the prognosis for breast cancer according to different subtypes. And this blue line is the luminal A, which is our most common subtype here, and that is associated with the best prognosis. But the luminal A, the basal-like, which is a subset of the triple negative breast cancers, is really associated with one of the more aggressive forms of breast cancer and has the poorest survival. So one of the things that our group had tried to do was to try and understand why is it that Black women are more likely to die of breast cancer compared to white women or to other racial and ethnic groups. And we conducted this study within the NCCN, which is a nationwide study, to try and look at this question. And what this graph shows us is if we look at in this study, all the Black women that were diagnosed with breast cancer relative to white women, they were 2 times as likely to die of their breast cancer relative to white women. When we tried to think of what were the factors that may contribute to that, whether it was tumor characteristics, their treatment differences, comorbidities, or other factors, we over here on the right, we took into account each one of these to try and see, was this an important factor that explained the differences? And what we found was that tumor characteristics, which does include the molecular subtype, explained about 24% of this twofold increase that we see comparing Black women to white women. We also saw that stage at diagnosis was an important contributor. And although it wasn't statistically significant, it was kind of marginally significant. I think the other important factor that contributes to some of this differences is body mass index. And you can see once we accounted for everything that we thought to account for in this analysis, there still was an excess risk among Black women of about 20% that we couldn't explain by looking at these factors that we looked at over here in this graph on the right. The other thing that we tried to do was, again, we know that Black women are more likely to develop triple-negative breast cancers, and triple-negative breast cancers are treated differently than hormone receptor-positive breast cancers. And so we wanted to try and see if we looked at the same types of tumor types, was there still a disparity between Black women and white women? And so the blue lines are looking at estrogen receptor-positive tumors, and we found that if we compared all Black women to all white women with estrogen receptor positive tumors, Black women still had a 2.5-fold or a 2.25-fold increased risk of dying from breast cancer relative to white women. Again, we kind of did this exercise of we accounted for all these different factors, including SES and BMI and tumor characteristics and treatment. There still persisted this disparity that we could not explain with sort of known factors that would be related to prognosis. In contrast, when we did this with triple-negative breast cancer, so comparing triple-negative breast cancers among Black women compared to white women, we saw that the initial disparity was much less. And once we accounted for some of these other differences, there really was no difference. So it really suggested that the biggest disparity or the biggest difference really was for these ER-positive tumors, which are the less aggressive tumor types, which does suggest that there are things that we weren't accounting for or could not account for in this kind of analysis, which may still be treatment related. It may be we were unable to look at delays in treatment. We were unable to look at how adherent over time people were. And so these are other issues that really need to be explored to try to better understand why there may be differences that continue to persist, especially for these less aggressive tumor subtypes. So in terms of racial disparities of breast cancer, it really is multifactorial. We know some of the biology is different. We know that stage made a difference, access to care, risk factors, and treatment. So trying to look at the epidemiology of COVID-19, this is a study that was done in New York City and really tried to kind of look at some of the demographic features along the continuum of COVID-19. And we know that there are many points that are really important in determining long-term effects of COVID-19 on outcomes. So in this study, what they did was they kind of looked at the entire population, and then they looked at the number of people who became infected. And so the sort of early part of the continuum of getting infected, we see very different infection rates that are occurring by race and ethnicity. So just in this first top panel, about 8% of the population in New York City, of white people in New York City became infected with COVID-19. In contrast, 18.7% of the non-Hispanic Black population and 28.4% of the Hispanic population became infected. If you go further on into the continuum in terms of who was hospitalized, and of those that were hospitalized, those that actually died from COVID-19, again, you see differences by race and ethnicity here, with Blacks experiencing the highest mortality rates relative to whites and Hispanics. So they went a little bit further to really try and explain these fatality rates due to COVID-19 and to try and understand how these differences may be playing out. And so this first one is really looking at the crude fatality rate, which is really the deaths per population. So comparing Blacks to whites, there's a 5-fold increased risk of death in New York comparing Blacks to whites, and 3.5 comparing Hispanics to whites. So at the population level, we see that Blacks and Hispanics were having higher fatality rates than whites. But for Hispanics, this was largely due to the fact that there was increased higher infection. So the second line actually is focused on once someone was infected, what was the death rate? And actually Hispanics had equal fatality rates comparing those that were infected to white women. However, for the Black population, it was almost 2.5-fold increase. So for Blacks, this was really driven by the overall fatality rate is really driven by both higher infection rates as well as severity of disease. And so I think thinking about it on a continuum is actually very helpful because depending on where in the continuum you see these differences, you may suggest different points of intervention to help build better health equity. And I'm sure you heard Dr. Phillips talk about social determinants of health before me, but I think it is a really important framework to try and think of, especially looking at, I think, both breast cancer and COVID-19. I think there are social determinants of health that are impacting long-term outcomes for breast cancer, as well as severity of disease for COVID-19. And I underlined, I think, some of the features that we had put all of these together actually for breast cancer survival. And I underlined some of these social determinants of health that are also, I think, relevant for COVID-19, including employment, healthcare access, income, and neighborhood. And you know, there are still biologic differences, certainly with the breast cancer that we showed in terms of tumor molecular subtypes. But I think, you know, many of these social determinants of health are upstream of some of these factors. And so a lot of the work that we're trying to do today is to really to see what is the what is this continuum and where along this continuum can we intervene to really improve health equity, both for breast cancer and for COVID-19. So in terms of the breast cancer epidemiology, I've shown you that incidence and mortality rates vary by race and ethnicity. White women are more likely to be diagnosed with breast cancer. Black women are more likely to die of breast cancer. I think it's really also important to recognize that other ethnic groups have much lower incidence and mortality rates. And I think there's actually a lot that we can learn by studying a more diverse patient population to understand why some may have higher incidence rates and some may have lower incidence rates. We also discussed some of the risk factors for breast cancer. There are a number of established risk factors for breast cancer. Many of these include reproductive factors and family history, which are not readily modifiable. There are a few modifiable risk factors, and I think the strongest modifiable risk factor, which may have the most impact in terms of breast cancer prevention in the future, really would be focusing on BMI, obesity, adiposity. And we've also seen that COVID-19, the pandemic, shares many social determinants of health that are related also to breast cancer survival. I also think it's really helpful when we think about this to think about sort of the disease along a continuum. There's not any one single thing I think that we can try and understand or try and intervene on, but I really think along the continuum there are many factors that are contributing to disparities of both of these. And just focusing on the breast cancer control continuum, even thinking about everything from the development of cancer, we did see those incidence rates vary by racial and ethnic groups and over actually the life course of the person. So I think thinking about opportunities for prevention, screening, we know screening is really important for early diagnosis as well as decreasing mortality. And in terms of treatment, there is a lot of work that's being done to try and understand adjuvant therapy, symptom management, and adherence to endocrine therapy, and all the way to end-of-life care. I think there are important areas to try and understand racial differences along that entire continuum. And similarly, in terms of COVID-19, everything from, we can see the differences that we saw with the different racial and ethnic groups. I think some of that can be attributed earlier on in the infection process for those that may be employed in frontline or service industries. Income plays an important role, housing density, and later in the disease, sort of those who become hospitalized to those that go on to die may be impacted by certain comorbidities, including diabetes and chronic heart disease. So we know that racial disparities in breast cancer survival and COVID-19 are multifactorial and occur along a continuum. The social determinants of health impact both breast cancer survival and COVID-19 infection, as well as severity. And understanding the main drivers of these differences is going to be really important and necessary to develop intervention strategies to improve health equity for all. So back to the question, in terms of the racial disparities, we know that breast cancer exists, and which of the following best describes this disparity? The answer here was C. Although white women have the highest incidence rates of breast cancer, Black women have the highest mortality rates. Thank you very much for your time, and I'd be happy to take any questions. Thank you.